first, and this is Kim McCleary. I'm President and CEO of the CFIDS Association of America, and it's my pleasure to welcome everyone to our 13th webinar in the 2010 webinar series. And we're delighted to have Dr. Peter Rowe from Johns Hopkins University with us today to share some great information about orthostatic intolerance, its management and treatment. We've had just tremendous response to today's program. I know this is a topic of great interest to many people in the CFS community, and we are grateful to have such a world-leading expert on the topic with us. Before we get started with Dr. Rowe's presentation, I'm just going to go through a few housekeeping things for those who are new to webinar technology or perhaps our series, just to give you some tips on how this technology works and what to expect. So as I indicated, this is our 13th webinar of the 2010 series. So that you know, Dr. Rowe and I are in different locations. He's at his office in Baltimore, and I'm down in Charlotte, so we can't see each other, and we can't see you, and you can't see us. So this is a bit to us like talking to ourselves. And it's a little strange. I'm used to it after 13 times, but I believe this is Dr. Rowe's first webinar. And but he told me earlier he's used to talking to himself. He's just not used to having an audience when he does it. So hopefully we will cope with that, and you will as well. We had about 270 people pre-registered for today's program. The opportunity to submit questions through the registration process enabled us to have some great information about the audience, as well as an idea of what topics you all are most interested in hearing about. We'll take some of those questions after Dr. Rowe's formal presentation, but if you have others, type them as you think of them. There's a little dialog box in the dashboard on the right side of your screen that should be popping up. And you have a little place where you can type in questions. Those actually come to me, and then I will address the ones that have to do with sound and picture and where to find recordings and that kind of thing, and I will save the others for Dr. Rowe. We are recording this program, and it will be posted online on our YouTube channel within a couple days' time, maybe even as soon as this evening, and we'll post the URL on our website and also on our Facebook page. Just as a reminder, Dr. Rowe is a physician, but he's not able to address individuals' questions about their symptoms, test results they might have received, or therapy that they're on. This format just does not lend itself to that, and we want to stay away from any problems that might be created with him trying to be a physician to people who are not his patients. So if you can help us respect that, that would be terrific. As I said during the registration process, we get some information about you guys as you sign up to participate, and we've learned that about 50% of the registrants for today have already been diagnosed with orthostatic intolerance, so it's a very knowledgeable audience about this particular subject. And another 30% said they had the symptoms of orthostatic intolerance but have not yet had formal testing, or the testing has been inconclusive. 60% indicated that orthostatic intolerance has a significant impact on daily life, and that's what I hear so much about from people when they discover this association between the two conditions. And only about 5% of the people who have OI indicated that it has little or no effect on their daily life. So that makes this a pretty significant symptom for people who are living with both conditions. And we've got a pretty strong repeat audience from our other webinars, with about 60% of people having participated in one of the other 12 programs that we've had. And again, this program and last week's program on disability have been the two that have generated the most questions in advance, which is interesting given that the center of gravity in the CFS world right now seems to be centered on XMRV and MLV. These two topics, I think, are real-world, everyday issues that people are dealing and struggling with. So I'm glad that we have these programs in the schedule, even though focus may be elsewhere at times. So without further ado or delay, it's my honor to introduce Dr. Rowe, whom I have known for, maybe 15 years, Peter?
I think,
close
at least.
to that anyway,
Yeah.
And we don't see one another often enough as far as I'm concerned. It's rare to find someone as knowledgeable and approachable and as self-effacing as Peter is, while holding such tremendous knowledge about a pretty unexplored area of medicine. He practices at the Johns Hopkins University School of Medicine and is, I believe, and he believes, the only endowed chair for chronic fatigue syndrome in the country, with an endowed chair that is uniquely titled the Sunshine Natural Wellbeing Foundation Professor of Chronic Fatigue and Related Disorders. And his slide presentation will give us an insight into what some of those related disorders are. Although his specialty is in pediatric and adolescent medicine, he also does see adults in his practice. And I think at one time was sort of the, he probably hates this comparison, but was the Dr. House of Johns Hopkins in a diagnostic clinic where he got all the weird cases, and you may still get a lot of weird cases.
Yeah, Dr. House without the oxycodone, though. I want to go on record with that.
And I don't think you have a cane either.
No.
And we won't ask you to play the piano. Maybe you can. And with colleague Hugh Calkins, also at Johns Hopkins, is credited with identifying the link between chronic fatigue syndrome and orthostatic intolerance in 1995 that really did descend the study of chronic fatigue syndrome on a clinical level in a new direction and offered many treatment opportunities that had not been recognized in the past. And I know that many people have experienced modest or great improvement by using a combination of these techniques that Dr. Rowe will describe today. So I am going to now attempt to turn the controls over to Dr. Rowe. And if you'll click on that little button, Peter, I think we'll see your slides. There we go.
Yeah. Okay.
Very good. So off we go.
And then, Kim, the thing that's in the upper right-hand panel of this, do I just
you can
minimize
click the
that?
little orange arrow and it'll go away.
Okay. Thank you.
Or it'll just slide to the right so that you don't have to see it.
All right. Excellent. Well, thank you. It's a pleasure to join everyone today and share some of the insights that we've been developing in about the 17 years I've been working in this field. I'm a pediatrician, as Kim said, and I've been primarily focused on treating adolescents and young adults, but the principles that I'm going to talk about today should apply to older adults as well. I wanted to thank the Sunshine Natural Wellbeing Foundation for endowing the professorship that allows me to continue doing this work. And we've also been very fortunate that a number of families have supported the efforts and the clinic here at Johns Hopkins as well, Bill and Vicki Boyce in particular. And so I wanted to thank all of those donors for their generosity and point out that without that, this work would have been a lot more difficult to perform. Well, today's topic is managing orthostatic intolerance. And I wanted to focus on the practical aspects of that, first by introducing the problem with a patient. I'm a clinician, and I find that that's the best way to focus my thoughts. And I'll describe a young man that we evaluated and treated recently, then move into a discussion of what we mean by orthostatic intolerance, a little bit on what the body is doing in responding to upright posture, the physiology of orthostatic intolerance, look at the common forms of orthostatic intolerance that we see in chronic fatigue syndrome, and then spend the balance of the time on treatment. And this includes both non-pharmacologic measures and medications. But one of the points I want to emphasize that I think doesn't get emphasized enough is that in treating orthostatic intolerance, it's not just a cardiovascular or an autonomic neurology problem. We have to address the contributing medical conditions that patients bring as well. Well, let's move to the patient. This was a 15-year-old boy that I evaluated earlier this year. And he had had this gradual onset of fatigue and lightheadedness when he was 13, about 2 years beforehand. And throughout the illness, he would awaken unrefreshed, even though he got what should have been an adequate 10 hours of sleep. He was tired all the time, and in the early phase of the illness, he would go to school, but he was really wiped out by noontime after sitting in class for 4 hours. And he would also get fatigued with shopping or any other physical activity. When we're talking with our pediatric trainees here, I always emphasize that any adolescent that can't tolerate going to the mall has to have something wrong, and it's not just a tongue-in-cheek comment. This boy had headaches. He had a lot of achiness throughout the body by the end of the school day. His shoulders were particularly sore, and he had some aches and pains in the muscles and joints throughout the body. Even though he'd been a child who'd been a very good student with no attention deficit disorder or other concentration problems, with the illness he was having a hard time with his focus. He was easily distracted. And as a result of the cumulative effect of all of these problems, which are familiar to this audience, he was put on homeschooling due to the fatigue for the 18 months before I'd seen him. Well, we investigated the lightheadedness that he was describing, and he was telling us he was lightheaded every time he stood up from either from the bed in the morning or from a sitting position. He had not fainted, but he had come close on many occasions. He'd learned how to prevent the complete loss of consciousness by getting to the ground sooner. One of the really fascinating things that jumped out at us in the history was that since he got tired, he would crave salt, and he even went as far as to keep a salt shaker on his night table in his bedroom, and he would sometimes pour the salt out and lick it out of his hand. Really quite a striking degree of salt appetite. The only other health problems he'd had up to that point were some hay fever and allergic rhinitis, and the family history was notable primarily for the fact that several of the relatives were quite flexible. Well, we looked at the workup that had been done by the physicians that had seen him before he came to me, and he'd had the standard exclusionary lab work that is recommended for CFS, along with a cardiac evaluation including an electrocardiogram and an echocardiogram because of the lightheadedness, and those were normal. And to investigate his headache, he'd had a brain MRI, also normal. So we then went on to examine him, and he struck me as a very mature 15-year-old, very pleasant, normal height and weight. His blood pressure and heart rate were fine for age. And the main things that were different with his examination were that the sclera of his eyes, the white of his eyes, had a blue tinge. And he had an abnormal Beighton score with 7 out of a possible 9 problems on the Beighton score. This is an index that's very simple to do in the clinical setting, and a score of 4 or higher indicates that the person has joint hypermobility. And we'll talk a little bit more about the Beighton score and joint hypermobility later. The other thing that he could do that was also striking was that he could pop his shoulders in and out of the joint at will. Once we'd seen this, we told him, you better stop that, because continuing to do that would set him up over time for some arthritic conditions later. And certainly that was part of why his shoulders hurt. We then went on to do a standing test, and if you look at the bottom of this slide, we had him supine on the table for 5 minutes. He then stood quietly against the wall for 10 minutes, and then he returned to the supine position. The light blue lines reflect his systolic blood pressure at the top and diastolic blood pressure at the bottom. Heart rate is in black. And when he was supine, his resting heart rate was 62. You can see that as soon as he stood up, his heart rate went up above 100 and peaked at 113. So he had a 51 beat per minute increase in his heart rate, and this brief period of standing that should be tolerated by healthy people, and healthy people would typically report simply being bored, this boy had lightheadedness, worse tiredness, and trouble concentrating during that time. So it reproduced his typical symptoms. Our diagnosis at the end of the evaluation was that he had joint hypermobility, He had orthostatic intolerance, the main form being postural tachycardia syndrome, defined by this huge increase in his heart rate, and he had some allergic rhinitis as well as meeting the criteria for CFS. So we treated him first by addressing the allergies with a standard antihistamine, fexofenadine, and because of his really striking salt appetite, we thought a good medication in that setting is Fludrocortisone or Florinef, and he worked up over a week to 0.1 milligram daily. We also gave him a potassium supplement because Florinef causes the body to urinate out more potassium, and this helps keep the total body potassium levels normal. Well, how did he do? He came back in a month, and he was less congested because of the antihistamines, and he was a different kid. He said that within a week of reaching the full 0.1 milligram daily dose of the Florinef, he had improvement in all of his symptoms. And so by this point, he had no further lightheadedness, no headaches. He had normal energy. His mother was just astonished that he was out helping one of the neighbors carrying a wheelbarrow full of rocks around for this guy. And there was no further post-exertional worsening of his malaise. So his wellness score was up into the 90s out of a possible 100, really feeling back to normal. Obviously, this was very gratifying. I don't want anyone to think that this is the most common response. This was certainly a very dramatic and complete reaction to very minimal intervention. But his case really emphasizes for us the potential for people to get a substantial improvement in their CFS symptoms when we address the orthostatic intolerance. I think also a point I want to make is that he had had these symptoms for 2 years, and so there was a long delay in getting him to an appropriate therapy, and if we had better recognition of these problems, he could have been treated at a much earlier point. Well, that by way of introduction then, let's move on to the definitions. One other slide beforehand that we'll come back to is that when we talk about the contributing conditions for orthostatic intolerance, this slide lists several of them that we will address later. This boy had, in the green at the top, the inhalant allergies, and he had the joint hypermobility syndrome contributing to his orthostatic intolerance. And one of the points I would make is that everybody is going to get to their chronic fatigue syndrome and orthostatic intolerance in a different way with different contributions from their life experiences and their genetic potential. So on to the definition and some aspects of the physiology. When we talk about orthostatic intolerance, this is a big umbrella term. It isn't one single disease. And Philip Lowe from the Mayo Clinic and his colleagues have said that orthostatic intolerance refers to a group of clinical conditions in which symptoms worsen with quiet, upright posture, and that can include either sitting for long periods of time or standing, and they're ameliorated or improved, although not necessarily abolished, by recumbency. Fairly straightforward description. The main challenge that we face when we stand up as humans is we've got to get blood consistently up to the brain. And when we stand, there is a gravitational pooling of blood that you can see depicted in this illustration anywhere below the level of the heart. So there's more blood that pools in the blood vessels in the abdomen, the legs, and the arms if they're hanging down. If we can't adapt to that shift of blood volume down to the dependent areas, then the brain doesn't get enough blood flow and there are consequences. We respond to this usually because there's initially a drop in blood pressure, and there are very sensitive nerve areas in the walls of the big vessels in the aorta and the carotid arteries that sense when there's a reduction in blood pressure. They fire off a message to the brainstem centers that control heart rate and blood pressure, and the response from the central nervous system is to increase the nerve activity in the sympathetic arm of the autonomic nervous system. That leads to about a 10 to 15, perhaps 20 beat increase in heart rate, a little bit more forceful contraction of the heart, and improvement in what the heart can pump out. But the biggest effect of this change in sympathetic nerve outflow from the brain is that there's better vasoconstriction. Norepinephrine is a big mediator of that, and this leads most of us to being able to get good blood flow to our brains within seconds of standing, and to maintain it if we have jobs like being a cashier or being a teacher or a policeman. Those are critical adaptations for normal life. If those things don't occur, then people get the symptoms of orthostatic intolerance that are shown on this slide. The ones on the left, lightheadedness, syncope, poor concentration, headache, blurred vision, are probably related to inadequate blood flow to the brain. In talking to the adolescents with these problems, I liken this to the fact that a car engine will not work if it's not getting enough gas. And so we need to have good blood flow to the brain to avoid these symptoms. Note that many of these overlap with chronic fatigue syndrome. We don't know precisely the mechanisms by which fatigue occurs, but it's an incredibly common symptom in every form of orthostatic intolerance that's ever been described. Patients with these problems also have intolerance of low-impact exercise, so they do worse with going to the museum, going to the shopping mall, and they tend to be better if they're in motion. Sometimes if they're able to play sports, that works better. Some of the other symptoms on the right relate to either inadequate blood flow back to the chest, which can give you a shortness of breath, the medical term for which is dyspnea. You can get chest discomfort. Some of these right-handed symptoms are also related to the high levels of epinephrine and norepinephrine that accompany the body's response to blood pooling in the limbs. So those include palpitations, tremulousness, and anxiety. You can see nausea and urinary problems at night, or nocturia as well. Many people also with orthostatic intolerance have temperature regulation problems. They feel cold all the time, or they get hot flashes, and these are probably related to the catecholamine surges that occur. Let's go then to the common forms of orthostatic intolerance that we see in people with CFS. The two main ones are neurally mediated hypotension, NMH for short, and this is a reflex reduction in blood pressure. We define it as a 25 millimeter of mercury drop in the systolic blood pressure with either standing or tilt table testing. And usually at the time blood pressure is dropping, we do not expect to see an increase in heart rate. With that, you should see reproduction of the typical symptoms that the person is complaining of. The second that has become more readily recognized, in part because it requires shorter testing, is postural tachycardia syndrome, or POTS. And for this diagnosis, as we saw in the boy I presented earlier, you need a 30 beat increase in heart rate, or a heart rate that reaches 120 or higher at any point during 10 minutes of orthostatic testing. With this diagnosis as well, we want to see reproduction of the person's typical symptoms. This slide is meant to summarize a big volume of the scientific literature on the factors that go into causing orthostatic intolerance. So let me walk us through that. In the upper part of the panel, one of the things that's been seen is that most people with orthostatic intolerance pool more blood in their limbs for a variety of reasons, not all of which are clear. They pool more blood in their limbs than does a healthy person. And they seem to have some defect in the ability to vasoconstrict, for the vessels to push that blood back up towards the heart. Many people also have a reduction in the amount of blood, including red blood cells and plasma, in their circulation. This is then made worse if they happen to get dehydrated with vomiting or an illness that doesn't allow them to drink much. If you have these two problems and then you stand up or undergo a tilt test, you get what David Goldstein at the NIH calls an increased sympatho for the sympathetic nervous system, adrenal for the adrenal gland and its production of epinephrine and other hormones, an increased sympathoadrenal response. And Goldstein would suggest that the way you get POTS rather than NMH depends on your early catecholamine response. If you have a higher release of norepinephrine, which is a very potent vasoconstrictor compared to epinephrine, you might develop POTS and maintain your blood pressure for a while. POTS patients, if you keep them long enough, very often progress to NMH during a tilt test. The NMH patients don't have to have POTS early on, and they seem to have a higher level of epinephrine compared to norepinephrine. And this may predispose them to fainting because epinephrine can cause dilation of certain vascular beds. Neurally mediated hypotension has a number of synonyms that don't make it easy for people to review this literature, but a few of them are listed here. It's been termed vasovagal syncope, neurocardiogenic syncope, vasodepressor syncope, neurally mediated syncope. We like the term hypotension because not all of the patients who have this problem have fainted. And so if you go to the doctor and say, I think I might have neurally mediated syncope, and you've never fainted, they'll look at you like you're from Mars. So we like the term neurally mediated hypotension instead. Here's a summary of the kinds of things that this has been associated with. This is by far the most common cause of recurrent fainting at all ages. It tends to be more common in women, in younger people, and in those who start off with a low normal or low blood pressure. And those features overlap a lot with CFS as well. It can be triggered by infection. That's been recognized in the past. Family members are often affected. And one of the things that led to this being misjudged as a psychosomatic disorder in the past is that the routine physical examination and laboratory tests were normal. Things changed when the tilt table test came along because it showed that with prolonged testing for up to 45 minutes or so, people's blood pressures would plummet. And the emphasis is that the hypotension here is usually not detected unless the orthostatic stress is prolonged. In our studies of people with chronic fatigue syndrome, the median time to develop this hypotension, even though they're symptomatic long before they have a drop in blood pressure, the median time to develop hypotension is 29 minutes. It's interesting and probably part of the overlap with CFS that in patients who faint with this problem, they can have fatigue for up to 72 hours after an episode of fainting. And the fatigue that occurs after this form of syncope is very helpful to people in the emergency room in separating it from fainting due to a heart rhythm disturbance. We think that this part of this process that patients have where they get fatigue when their blood pressure plummets, it causes a buildup of a debt of fatigue if they have recurrent lightheadedness throughout the day, and that may be part of the mechanism for generating fatigue in those who have both NMH and chronic fatigue syndrome. This shows us a standing test again, showed earlier. The person is supine for a few minutes, then stands up, and then returns to the supine condition. In contrast to the boy I showed you earlier who had POTS, this patient had a modest increase in heart rate with standing. It was no more than 27 beats per minute, so it didn't meet criteria for POTS. And eventually, blood pressure plummeted at the 5-minute point, and the systolic pressure went down to about 50, and the person lost consciousness. In this time, even when heart rate and blood pressure were fine, the person was already lightheaded, uncomfortable, didn't like this feeling. David Bendit has produced a number of papers, and others have confirmed these findings, showing the catecholamine response to upright tilt in people with recurrent syncope. Now, these were not people with CFS, but we assume that something similar is happening. He looked at epinephrine in the top panel, norepinephrine in the bottom panel. The healthy individuals were the ones with the dashed lines. The syncope patients were the ones with the solid lines. And you can see that the norepinephrine response was about the same in the fainters, but the epinephrine levels went sky high compared to healthy controls. And this is a common feature of the NMH response. Shifting to POTS, this is also a very common disorder, more common in women than men for reasons that aren't entirely clear. And it can have both a gradual insidious onset, like it did in the 15-year-old I talked about earlier, or it can happen suddenly after an apparent viral infection, after Lyme disease, after surgery, either because of something related to the procedure or to the lying in bed for a prolonged recovery, and it can occur after trauma. I'm not going to cover these more medical issues about the pathophysiology, about how it occurs. Suffice it to say that there are many ways of getting to the point of POTS, and we don't even agree on the classification schemes for this. But I mention them to point out that POTS is not any more of a uniform problem than CFS itself is. In patients with POTS, fatigue is a common symptom. They also have exercise intolerance. They get palpitations, and these can be quite disabling. An older paper, this is the another schematic of the heart rate response, and in this younger patient, during the supine period, she was a little apprehensive about what was to come, so her resting heart rate was much higher than one would expect in a healthy individual, about 100, but it went up well above 120, and then when she'd finished the test, she was much closer to her own baseline. Her heart rate essentially doubled with 10 minutes of standing. Now, I'm not a big exercise fanatic, but it even takes me 20 minutes to raise my heart rate that degree on a treadmill. So again, it points out the degree of physiologic abnormality patients are facing. An older study by Rosen and Cryer from 1982 showed that in a single individual with POTS, these are panels showing in the dashed lines the normal norepinephrine response to 10 minutes of standing. And then each of these curves was this individual's response on a recurrent basis. So her norepinephrine response was very high. Interestingly, when they applied external compression, and we'll come back to that concept with treatment, when they applied external compression using masked trousers, these old inflatable pants that used to be put on people when they got into trauma, with that, this individual had a normalization of her norepinephrine response. Similarly, when she was given a big load of intravenous saline, the norepinephrine levels did not go up, and we've found that this is a very helpful thing to do on occasion. We'll come back to that as well. In both POTS and hypotension, one of the clinical features we'll see, and many of you will be familiar with this, is that there's a dependent acrocyanosis. Acrocyanosis just means peripheral cyanotic appearance, this dark purple appearance. On the left is the hand of a patient who had been standing for no more than 3 minutes at this point. This is my hand behind to show the difference in color. You can see some mottling throughout that. Here, I went over to her and placed my fingers against her leg, stepped back, picked up the camera, focused it, and took a picture. Several seconds elapsed, and still there was no blood flow back to that region. And this is really one of the more striking features of patients with orthostatic intolerance. Not all of them have this degree of acrocyanosis, but it really reminds you visibly that there is an important circulatory disturbance. I've put in some slides at the end for people to look at later because I think we'll run out of time, but I just wanted to mention that one thing that can lead to this kind of dependent acrocyanosis and to orthostatic intolerance, like we saw in the first patient, is either Ehlers Danlos Syndrome or joint hypermobility. Joint hypermobility is fairly common in the population. Ehlers Danlos Syndrome is thought to be a frequency of 1 in 5,000. These are people who have extreme laxity of their skin, their ligaments, and their blood vessels. So they're often contortionistically able to move their joints around. They have very stretchy skin at times, and they have early varicose veins. And they also have fatigue and widespread pain of uncertain etiology. And so obviously that overlaps a lot with CFS and fibromyalgia. And we've been very interested in these connective tissue abnormalities as problems that predispose people to excessive pooling in their limbs. When they get blood flowing down into their legs when they stand up, their vessels don't constrict anywhere near as well, it would seem. These are some of the pictures of patients from the clinic who have joint hypermobility, and these illustrate elements of the Beighton score that I'll show you again later, but the ability to bring the fifth finger back past 90 degrees, thumb to the forearm, hyperextensibility of the elbows. You can see this is a more than 10-degree angle, palms to the floor, and a similar hyperextensibility at the knees. Well, we don't have time to go through this list, but I just wanted to mention some of the things that make orthostatic intolerance an important topic. One is that it's very strongly associated with chronic fatigue syndrome, and it used to be a controversial statement, but I don't think anyone can really object to this anymore unless they have a strong dislike of reality-based medicine. There have been some lovely studies coming from all around the world, and some of the best have come from Vegard Willer's group in Oslo, Norway, showing that you can identify orthostatic changes in those with CFS with very small degrees, 20 degrees of upright tilt. We also know that upright posture consistently aggravates chronic fatigue syndrome symptoms, and these are present, these symptomatic increases are present before you see big heart rate and blood pressure changes. We know that clinically, treating orthostatic intolerance can improve chronic fatigue syndrome symptoms. Orthostatic intolerance can be a primary abnormality, seemingly the only thing driving the process, or it can be a consequence of a variety of other problems, such as deconditioning or lack of activity. It can be being driven by an underlying infection, which is particularly interesting in light of the XMRV data, if it's all validated, and in a much better known problem of Lyme disease, which has a lot of overlap with orthostatic intolerance problems. So I think it's very important to evaluate patients carefully for these non-cardiovascular problems, and I think it behooves us to find a way to get people good general evaluations in addition to the subspecialty care. We know that POTS and hypotension can occur in the same person. They are not mutually exclusive disorders, as sometimes is suggested by the literature. The good thing is that the treatment of these two problems overlap. So when you find one, let's say we identify POTS in a 10-minute standing test, there's no particular reason to go on to doing a prolonged tilt table test to identify whether they also have NMH. So on to the treatment, and we begin with non-pharmacologic measures. The statement on this slide is one that I make in the clinic, and when I do so, that people should avoid the things that bring on their symptoms, I get this unusual stare that any of you who have adolescents in your family will recognize, and the translation is, well, duh. Of course you want to avoid the things that bring it on. But sometimes it's worth listing them anyway, And these are the precipitating factors for NMH and POTS. Remember that diagram I showed you earlier, that one of the things that leads to the problem is increased pooling of blood in the limbs or decreased blood volume. Well, how do you get to that point? One is obviously prolonged sitting or standing, and so when people can, we want them to avoid this. If you're an adult, standing in line is tough, so you want to shop at non-peak hours. If you're sitting for long periods of time, try and find a way to move your legs around. Get up, walk around. Warm environments cause increased pooling of blood because they shift blood flow to the skin as we try to dissipate heat. So warm environments like hot showers and hot saunas and hot tubs are really tough for patients with these disorders. We recommend that people try and get the shower temperature down lower. This is partly why people with NMH and POTS can swim in the ocean temperatures, but they are really in trouble when they're walking on the beach. The ocean temperature acts as a vasoconstrictor. For those in really hot climates, some patients have found that cool vests, these vests that have packs of cooling material in them, used by firefighters and other people who work in hot environments, they can sometimes be quite helpful. We know that sodium depletion or inadequate sodium intake reduces blood volume, and so some of our patients have simply needed salt to be increased. That's not the common presentation. Those it's rare that that's all people need. But in primary care settings, that may be more common. Prolonged bed rest will also decrease your blood volume, in part because you're not getting up to drink and move around, but we'll come back to that concept later. If you have varicose veins, that's a site in which more blood can pool in the peripheral circulation. In adults who have other forms of orthostatic intolerance, high carbohydrate meals tend to cause more blood to pool in the abdominal vasculature, and so people advise against high carbohydrate meals in that setting. This hasn't been studied as much in people with CFS, but it makes sense for a lot of reasons to avoid really concentrated sweets. Medications like diuretics, vasodilator substances, or alpha blocker drugs, some of these include things like compazine and Phenergan for nausea. They can all lower blood pressure, as can, in some patients, the tricyclic antidepressant drugs that are used for pain. They're not contraindicated, but we occasionally see people who are tried on amitriptyline and really get much, much more lightheaded. Alcohol can cause both a flushing of the skin, so blood flow going to the skin, and increased urinary outflow, so you're really working against yourself with alcohol, and many of our patients find that it just makes them too sick. Also, another precipitating factor is the increase in catecholamines. We know this is happening with NMH and POTS, but also it'll occur in response to virtually any stress, whether it's a mental stress or an emotional stress. We can't get rid of that in life, but we can modulate it. Exercise can increase catecholamines. Pain can as well. Hypoglycemia is a factor that is often associated with lightheadedness, so it's good to detect that. Some of the medicines we use for asthma, like albuterol or epinephrine, can make the existing increases in catecholamines worse. And many of our patients with asthma who take albuterol puffers get very shaky afterwards. We try to shift them to asthma treatment that involves more inhaled steroids. Continuing with non-pharmacologic measures, one old one that was published in 1944, and you'll laugh at the appearance of this hospital bed, is to raise the head of the bed. It doesn't have to be as extreme as you see in this picture, 10 to 15 degrees of elevation of the head of the bed, and we recommend 2 red bricks as an example. That can fool the kidneys into an anti-diuretic effect, so that there's better preservation of blood volume, less urine that's produced at night, and this can be helpful if people tolerate it. Compression garments are much easier to adopt, and support hose are a mainstay if you can get people to wear them. I had very little luck getting most adolescents to do this until recently, and I'll show you why. The waist-high garments in studies are better than the thigh-high, and those are better than the knee-high garments, probably because some of the pooling is occurring in the abdomen. Body shaper garments that also involve abdominal compression can be helpful, as well as abdominal binders. And I've got a bunch of these to show you on the next slide. Here's somebody with the Jobst ultra sheer stockings. This is a Spanx garment that is meant to shape the body but provides some very good abdominal compression and upper leg compression. Here's an abdominal binder that compresses the abdomen, a thigh-high stocking, a different kind of stocking that's used in travel. And one of the things that makes these a little bit more fashionable for adolescents has been the development of more compression garments from the athletic garment industry. And here's somebody wearing an Under Armour at the bottom right, Under Armour recharge suit, said to improve vitality for athletes after a workout. We wondered if that would work for our patients, and so we got a few of these and did a pilot study with 5 patients. They were taking their usual medicines except the ones that they could afford to stop the day of the test, and we had them do 2 5-minute standing tests in random order, separated by 15 minutes, one in which they had the compression suit on and the other without it. You'd think without the suit they'd have a higher heart rate if compression helps, and that was in fact the case. When they had the suit on, there was a very nice reduction in heart rate for 4 out of the 5 we tested, suggesting that further work on this kind of garment might be very helpful. And again, it sort of gets around the stylistic objections that many adolescents have to the other forms of compression devices. There are also a variety of other non-pharmacologic measures that use the muscles in the leg as a pump. These are termed the postural countermeasures, and they include things like standing with your legs crossed, squatting down, sitting with the knees drawn up to the chest, which is a common thing for the adolescent girls. Leaning forward sitting tends to engage the calf muscles a bit more. Elevating the knees when you're sitting on a footrest, for example. And another technique that helps reduce lightheadedness when you stand up is to clench your fists. And if you all do that now as you're listening, you'll notice that as you clench your fists, your arm muscles also start to contract, and that's probably pushing blood out of the arms and making it more available for the heart to send up to the brain. A picture of this is shown in this slide from Dr. Smits in the Netherlands, showing an individual with orthostatic hypotension who is crossing her legs. He measured beat-to-beat blood pressure, and it showed that when she was supine, this was the blood pressure here, and when she was standing with her legs crossed, it increased and kept her able to cook or wash dishes or do things upright. The lower the chair, the higher the elevation in blood pressure, and that again gets at this notion of trying to get your knees higher than your hips. With regard to fluids, you want to aim for at least 2 liters a day, drinking something about every 2 hours. And for children who are in school, you need a permission slip so they have access to fluids. We also think it's important to avoid, even those with the greatest degree of fatigue and sleeping during the day, we don't want them sleeping for more than 12 hours at a time, because the more you exceed that, the more you're likely to be dehydrated when you get up again, and you'll simply start the whole process over again. They can be wakened, hydrated, they can go back and nap if they have to, but we try to limit the amount of sleep somewhat. Salt is a topic that many of you commented on in your questions. We generally just increase that according to taste, and we supplement it with salt tablets. There's a buffered form of salt tablet called a thermotab, and we typically will ask people to take 2 of those 3 times a day with meals. Some people get nauseated with salt tablets, in which case they don't need to take them. There are a lot of healthy ways to get salt in, like olives, pickles, soups, and so on. If you have kidney stones or some inner ear disorders, you won't be able to increase salt as much, but fluid intake with water is fine. For those who are worried about the medical statements that there should be a universal reduction of salt intake, that these have been coming out of the medical community for over a decade. There are some real cautions to that, and they've been nicely articulated by Dr. Michael Alderman in an editorial in the Journal of the American Medical Association that should be available online from February 2010. He's a very articulate opponent of that kind of widespread sodium reduction for all people. We've been talking a little bit about why bed rest is a problem. Actually, before we get to that, there's one more slide about the benefits of intravenous saline. We know from clinical experience, but also from some very nice studies by Berklow and others, that heart rate and blood pressure responses can change in response to head-up tilt testing before and after intravenous saline. And in the left panel, what you see is that when the person is tilted upright, heart rate goes up to above 110 in this panel. They're then given saline intravenously, and the tilt test is repeated, and you can see a much more gradual increase in the heart rate response. The people fainted more commonly when they were not given the saline, and they kept their heart rate and blood pressure in a better range after saline. The systolic blood pressure is also maintained better after the IV saline. And while this isn't a very good solution on a daily basis, we will often use IV saline infusions on a once-a-week basis as needed for those who have particularly severe symptoms, or for those who have been going along well, get a sinus infection, and are really much more dizzy and not recovering readily. The saline seems to, in some ways, look like we have rebooted their autonomic nervous system. Obviously that hasn't happened, but they feel much better after the saline infusion. Exercise is a tough one because here's the paradox of CFS. We know from the research studies that graded exercise seems to help, but part of the definition is that there is post-exertional malaise. We have to get people moving, and for the people who are the most impaired, they need to start exercising slowly. A couple of minutes a day is fine, increasing gradually, never doubling their exercise volume on a given day, even if they feel good that day. Go up very slowly. And there's some work suggesting that recumbent exercise might help at the outset. We also have been doing work over the past 10 years with our physical therapy colleagues, including Rick Violand in Baltimore, on how manual forms of physical therapy may be a bridge that allow people better tolerance of exercise. But in general, our message to the adolescents is that inactivity is the enemy. And here's why. This study was done with NASA volunteers, and it looked at people who were put on bed rest for up to 220 days, not even getting up to go to the bathroom. And in the first 2 weeks or so, look at what happened to their plasma volume. They dropped down somewhere between 9 and 18% of their plasma volume in 2 weeks. So it's easy to imagine that if you get laid low by a bad influenza or bad mononucleosis, you're going to have a severe reduction in your blood volume. That would then make you lightheaded when you got up. You'd think, gosh, I better lie back down. I'm really feeling lousy. And that would be precisely the wrong thing to do, because inactivity will simply make this worse. These authors also showed that if they kept people lying flat but gave them an exercise bike for their legs, that they would get less of a reduction in blood volume. On to treating the contributory conditions. A couple of minutes on that.
Can I stop you for 1 second?
Yeah.
Can you just explain the terms recumbent exercise and manual exercise?
Yeah, sorry. The recumbent exercise would just be like a reclining exercise bike, or you could be lying on your back and doing leg lifts or core work or strengthening exercises. Manual physical therapy is distinct from exercise-based PT in that the therapists try to treat any restrictions in your range of motion, any tenderness in the muscles, any areas of abnormal nerve glide so that you can then move on to tolerating exercise. The goal of both kinds of physical therapy is to get people exercising again. The manual therapy approach tries to address the problems that people have at baseline, and we find them pretty commonly in CFS.
Thanks.
The various issues on this slide are things that can contribute to orthostatic intolerance. Depression can do so, but notice that the arrowhead goes in both directions. So that if you're tired all the time and can't do much, it's not uncommon for depression to appear as a secondary phenomenon. Anxiety and orthostatic intolerance share a lot of the same pathophysiology, but we feel that if these two are very problematic, you've got to get them treated before this is going to improve. Perhaps 20% of the adolescents we see have had a history of upper abdominal pain, gastroesophageal reflux, and some sort of appetite disturbance that makes them fill up quickly, sometimes with mouth ulcers and other symptoms. And the most common thing that they are allergic to is cow's milk protein. And they often have a history of a lot of colic and spitting in infancy. These are delayed allergies. They don't get picked up by the standard skin tests or blood tests, but clinically getting rid of these when they're present can help you treat what remains with the orthostatic intolerance. Allergies and asthma can contribute. Infection, as we talked about earlier, can. The movement restrictions we were just mentioning. Migraines can be associated with orthostatic intolerance, and vice versa. In fact, some people who have headaches have the headaches improve when you address the orthostatic problem. There's a subset of patients, we don't really know how large it is, who have neurological evidence of exam abnormalities and MRI evidence of either Chiari malformation that crowds the base of the skull or cervical spine stenosis that also pinches the cervical spine. And when those are present and the examination is abnormal, they can contribute to orthostatic intolerance. We mentioned the Ehlers Danlos Syndrome issues, and some women who have chronic pelvic pain that's worse when they're standing have varicose veins in the ovarian vein distribution in a condition called either pelvic congestion syndrome or pelvic vein incompetence. And if that's treated, you often will see clinically improvement in orthostatic intolerance. These aren't the only comorbid conditions, but they're important to address. Okay, on to medications for a few minutes. I want to just give you an overview again of how we approach this. We try to start with single drug therapy and, if needed, move on to what I call rational polytherapy. In other words, things that work on the problem from different directions. Going back to the diagram I showed you earlier, if part of the problem is increased pooling and diminished vasoconstriction, it makes sense to try vasoconstrictor drugs. If there's a problem with low intravascular volume, use volume expanders. And if the surges in epinephrine and norepinephrine are a problem, we can block their release or the effectiveness of them. So let's look at some of the agents that can do that. We can bump up blood volume using sodium orally and occasionally intravenously, as we discussed. Florinef, as you saw earlier. Clonidine is interesting because it was first introduced about 50 years ago as an antihypertensive, but it helps expand blood volume for a subset of people who have orthostatic intolerance. Birth control pills can be very helpful for adolescent females especially, whose menarche occurs around the time they're getting orthostatic intolerance, and they are a good agent if the person has bad menstrual cramps, severe acne, or marked increases in their fatigue at times of their periods. The drugs that block catecholamine release or effect are the beta blockers. Disopyramide or Norpace can do so. There may be some central nervous system reduction of catecholamine release by the SSRI drugs, the selective serotonin reuptake inhibitors that we know by the terms Prozac, Zoloft, Lexapro. And another antihypertensive group, the ACE inhibitor class, can also block catecholamine release and effect, and that's been shown in a randomized trial, in fact. We are using probably more vasoconstrictors over time. One of them is Midodrine. The stimulants like dexedrine and methylphenidate or Ritalin can do so. The antidepressant drugs also have some vasoconstrictor effect, and these include the serotonin norepinephrine reuptake inhibitors like Effexor and Cymbalta. There are alternative medicine forms of medication that cause vasoconstriction, not as well studied obviously, but these include horse chestnut seed extract. And for those who are hoping for advances, L-DOPS, or droxidopa, is a drug that's been available in Japan and elsewhere in the world for a long time to treat orthostatic intolerance. It seems to be fairly well tolerated and doesn't have a lot of side effects. That's currently in trials in this country and may turn out to be a very, very helpful adjunct in treating orthostatic intolerance. One other one that's emerged on the scene in the last 5 or 6 years has been pyridostigmine bromide, a drug previously used for myasthenia gravis. The brand name is Mestinon, and this works very nicely in some patients. A couple of minutes on selected medications, and I think I'll stop. Florinef is a drug that mimics one of the body's own hormones, aldosterone. It's been around for decades. It helps you reabsorb sodium in the kidney, expanding blood volume at least initially, and then it seems to work over time by improving the small vessel's ability to constrict. Side effects are not uncommon: headache, swelling, high blood pressure, low potassium, very occasionally depression and mood, and obviously you stop the medication when these problems occur. We tend to use pretty low doses, 0.1 milligram a day, occasionally up to 0.2, but often find that above that, even though doses higher than that are recommended in the literature, we often see problems. We recommend supplementation with potassium chloride when you start treatment to avoid total body potassium depletion over time. With Florinef and Midodrine and a couple of the others in our paper from 1995 that Kim was referring to, we saw a very nice improvement in the general sense of well-being over a couple of months of therapy, going from about a 35 out of 100 wellness up to about 70. And some people had really lovely improvements. And this is essentially what we continue to see. When we did a Florinef randomized trial where we took people who had a positive tilt test and randomized them to Florinef or placebo, kept them on treatment for 10 weeks and brought them in for a repeat tilt test, what we found was that it didn't work anywhere near as well as we thought. The difference between the placebo group and the Florinef group was only 4%, and that was not statistically significant. The patients, though, in this study didn't increase their intake of sodium. That might have been a design flaw on our part. We didn't increase above 0.1 milligram a day because we thought patients would know which drug they were getting, placebo or Florinef. And it may be that it's important to get at the problem with Florinef at an early point. 71% of the people in this study had had their chronic fatigue syndrome for 3 years or more. So we couldn't really tell if it made a difference for people who'd had the disease for a shorter period of time. We also didn't enroll patients under 18, so Florinef might be quite helpful for adolescents. And in a trial, you can't get rid of the background noise of the other contributing medical conditions that you've seen in the diagram. So it's a real challenge for us in designing clinical trials to account for the number of things that could mess up the response to a given single agent. Midodrine is in the news as well because about 2 weeks ago the FDA announced that it was going to withdraw this drug and the generic forms of the brand name Proamotine from the market because the manufacturer, Shire, had not done studies to their satisfaction to support the efficacy of the drug. This is going to be a giant problem for our patients because this drug has turned out to be fairly helpful for a subset. It's a vasoconstrictor that, unlike the stimulant drugs, has no central nervous system effects. It has a minor disadvantage in that the duration of action is only 4 hours, so you need multiple doses during the day. It gives you some scalp tingling, your hair stands on end, and it can lead to hypertension if you're using too much of it. Usual doses are listed here, and I wanted to just show one study from England from 1998. So when you see the FDA comments that this drug doesn't have any support, evidence basis for its use, here's a study of people with recurrent syncope randomized to placebo or Midodrine, and 10 of the 16 who got Midodrine versus only 2 of the 16 had a normal response to head-up tilt after they were on the drug, and they had much more symptom-free days. There's a second randomized trial in children, so it's absolutely not the case that this drug has no evidence base, and I would encourage people to go to the FDA website and register their disapproval. This drug being removed from the market will remove one of the more helpful medications that we've had over the last 12 years. We use a lot more of the stimulant class because they can help with vasoconstriction. They can cause some insomnia, reduced appetite, moodiness, agitation, but using the same doses that one uses for attention deficit disorder can be very helpful. And so many physicians are quite comfortable, especially the pediatricians, in trying these. There are also a couple of background articles I've listed here for the use of the stimulants in orthostatic intolerance, and 2 small randomized trials of dexedrine and methylphenidate for chronic fatigue syndrome, both showing some improvement in CFS symptoms. So the notion that we don't really have anything to support the stimulants is also incorrect. Beta blockers, I'll just mention briefly, can block the epinephrine-induced vasodilation. If you use too much of them, they'll make you more fatigued and lightheaded. You have to watch for reduction in the mood, and one of the questions that was submitted had to do with the occurrence of coughing and wheezing after starting beta blockers. We find that if that's mild, we can counteract it with an inhaled anti-inflammatory steroid like Pulmicort or Flovent, and if the beta blocker has really been helping with the fatigue and lightheadedness, that allows them to stay on the drug. But you'd have to be cautious about using these in people with bad asthma. Low doses appear to be better tolerated than the high ones, leading Satish Raj from Vanderbilt to comment in the title of his article in Circulation that confirmed this, that less is more when it comes to the beta blockers. Clonidine, I would mention, can expand blood volume. It is also a second-line treatment for ADHD, and it can help people get to sleep at night. So it addresses one of the CFS symptoms that plagues us a lot. It doesn't work for everybody. There is a randomized trial of clonidine underway in adolescents with Vigard Willer's group in Oslo, and I would look for those results in the next year. You can't stop this drug dramatically or quickly, or else you get a rebound hypertension. The SSRI drugs, I'm going to skip over in the interest of time. Pyridostigmine can improve vagal tone and lower heart rate. And the adverse effects are listed here for people to look at. One study from the group at Mayo showed that heart rate responses before medication in the supine position and then with tilt were lower when they were on the pyridostigmine. And this drug is, again, helpful. You have to hunt and peck for something that works for each person. How do you select the initial therapy? Well, you can go with an algorithm. Here's one from the folks in the pediatric neurology group at Mayo for POTS, and they will do all of the non-pharmacologic things we mentioned, and then they suggest that beta blockers are their first line, Midodrine first or second, Florinef second line, the antidepressant drugs third line, and others are rarely used. My approach is a little different, but not far off. I like to individualize it based on what's the person's systolic blood pressure. If they're really low to begin with, let's try Florinef or Midodrine. If their heart rate goes up a lot, a beta blocker might be good. And then, like in the patient I presented to you earlier, if the person has a high salt appetite, Florinef is a very good drug in that setting. Headaches, you can kill 2 birds with 1 stone because headaches can be treated with beta blockers. If the adolescent girls have a lot of menstrual cramping or worse fatigue with their periods or acne, birth control pills, and even Depo-Provera can help. If there is comorbid anxiety or mood is low, that's a good idea, a good time to treat the orthostatic intolerance with these drugs that will also address the mood and anxiety issues. One of them, Cymbalta, has been studied in fibromyalgia and shown to be effective, so if there's a lot of pain, that might be a good first choice. If there's a family history of attention deficit hyperactivity disorder, even if your orthostatic intolerant patient doesn't have that, stimulants might be good. And in the hypermobile population, we found that the vasoconstrictors are particularly helpful, although we don't have any formal evidence to prove that. And then lastly, just want to emphasize that the management of this disorder really requires a lot of attention by the patient and the practitioner to the factors that can aggravate symptoms. You have to be willing to try several medications before you find a good fit. Medicines can treat the symptoms, don't necessarily cure the problem, not unlike asthma. We give medicines for asthma, but we're not trying to cure it. We don't know how to do that. And I think management of the orthostatic intolerance is part of a comprehensive program of care. The last group of slides really are for people to look at later. They look at the association more carefully between joint hypermobility, orthostatic intolerance, and CFS. So let me, at this point, stop, and Kim, hand it back to you for the questions.
Well, we'll let you keep the slides up in case you want to refer back to any one of them as we go through the slides and as we go through the questions. And in addition to all those that I sent you by email, there have been a zillion others that have come through while you've been talking, and I've tried to answer some of those.
I'm only going to take on the first million.
Well, you're generous to do that. One of the ones that keeps popping up is whether these conditions are mutually exclusive of high blood pressure. In other words, can people who have high blood pressure on a normal basis or on a, at a baseline measure still be subject to orthostatic intolerance problems?
Yeah, the short answer is yes. People with higher baseline blood pressure have some protection in that they have a better buffer before they drop down to a blood pressure that's low enough to interfere with brain blood flow. But there are also problems with people who get white coat hypertension. Their blood pressure is always up when they come to the doctor's office, but if they measure it at home, it's actually not elevated. So that's a potential area where somebody with supposedly high blood pressure could also have orthostatic intolerance. And then in POTS, I can't remember who first described this, but one of the responses to the surge in norepinephrine when people are standing is that during tilt or standing, blood pressure will go up rather than down. So that you can get an orthostatic hypertension as a response to standing. So I wouldn't exclude high blood pressure as something that prevents you from having these conditions. And certainly people with high blood pressure who faint frequently, as long as there's not a known cardiac problem, may very well have the neurally mediated hypotension response.
This answer will be challenging, but what types of doctors normally do the testing for orthostatic intolerance and the therapy, and can you expect to get both from the same individual?
Well, I would answer, this is not at all self-serving, Kim. I would answer that the really good doctors evaluate this stuff.
That's an easy thing for people to find, I'm sure.
That's my one joke for the day. But anyway, it's tough because in our institution, the adult cardiologists who we first worked with on these problems found that they really needed to keep their time free for the patients with life-threatening heart rhythm disturbances, which require 6 or 8 hours in the electrophysiology laboratory doing intricate catheter-based studies. So in many ways, they just aren't the right people to be handling the finicky trial and error approach that we need to do for orthostatic intolerance management. So they have expertise, but they don't necessarily have time. there aren't very many autonomic neurologists who focus primarily on this. We have one in the Baltimore area, Dr. Ramesh Khurana. He's going to be overwhelmed by the demands for everybody who has these disorders to be seen. And if you're lucky enough to live near the Mayo Clinic or near Vanderbilt, where they've accumulated more than their share of autonomic specialists because of very good planning and emphasis by those institutions, you can often get more help. But I think what people need to do is go to their regular physician and bring them information that will help them understand these problems. I think we need better education of all the physicians, given how common these problems are. And often I get the most satisfying interactions with family doctors or pediatricians who call me, want to know how to handle this for a kid that they've got in their practice or an adult they've got in their practice, and they can roll up their sleeves and try things. I'm a general pediatrician. I'm not a cardiologist or a neurologist. I've learned about this in practice, and I don't think it's that hard to do, provided you're seeing enough of the patients that you get some familiarity. So I think given the absence of CFS specialists and orthostatic intolerance people, we've got to have better liaison with the primary care docs.
Do you have a favorite article that you would suggest people take to the physician that knows them best as an introduction to these issues if they're not already familiar?
There are a bunch that are pretty decent. Blair Grubb in Toledo has been a terrific educator of people in the general population, a very creative clinician and researcher in this area. And a lot of what we use I've adapted from things that Blair has written. So you could look for his articles and books. There are a number of good review papers by people that whose names you'll recognize, like Philip Lowe from Mayo. Julian Stewart in New York has got a number of good reviews on the treatment of POTS. Blair Grubb, Satish Raj at Vanderbilt, or David Robertson, his chief, are among the people who write very well on this topic and do lovely research. So you can get these. There are also a couple of web groups. The CFIDS Association has been an early innovator with the recognition of the importance of orthostatic intolerance, and on the website, or on the CFIDS website, I think, Kim, there are some papers that people can look at. And also there is the National Dysautonomia Research Foundation. They have some information, and DynaKids. So you can find this on the web.
And we will pull some of the additional URLs that aren't up on your screen at the moment and put those into the follow-up email that goes out to everybody who participated today, because many people have asked for resources to share with their healthcare professionals.
And I've got a handout that we've produced in our clinic that I'm happy to share with you, so that you can post that. And
thank you.
And that one is written for parents of my adolescent patients and the adolescents themselves, so it's a little freer of the medical jargon, but at the back of it we've got a 2-3 page listing of the different articles that the doctors might be interested in looking at.
Great. There were some questions about different substances and how they interact with orthostatic intolerance, caffeine being one of them, and licorice root, which is supposedly a natural form of the same substance as in Florinef. Any comments on either of those?
Yeah, caffeine is an interesting one, because some people are told, oh, you must always avoid caffeine. But it has a couple of properties. It is a vasoconstricting stimulant, so it might help some people with their orthostatic intolerance. The balance depends on how much it's also causing palpitations and heart irritability. You know, most people who drink way too much coffee are really jazzed up and agitated and have palpitations. So you've got to make that balance. And coffee and tea both have a diuretic effect. So if you get more loss of fluid through the kidneys than you do vasoconstriction, caffeine probably won't give you any boost. But I don't think it's an absolute contraindication in moderation. Licorice root is an interesting one because it has many of the same properties as fludrocortisone, and it has been used for centuries as something that helps with preventing or treating stomach ulcers. It's in most Chinese herbal remedies that address fatigue, and it probably has some biological effect. The hard thing is to know, as with a lot of these supplements that are not governed by the FDA, hard to know what you're getting. When I explored this about 15 years ago with a couple of patients, they would come in with these tubs of this tarry looking black material that was unpalatable. So I couldn't get any of the adolescents to use it. Some people are very enthusiastic about using this stuff. I just find that it's much easier to know what I'm giving when I give people fludrocortisone than some unknown product that could have impurities in it that would cause other problems. So I tend to stay away from that one.
Okay. A few questions here that actually hit home with me. Peter knows my history on this. When I was 2 years old, I began fainting a lot, and it took me until after I had met Peter to get a diagnosis, and it turns out that I have had some of these orthostatic intolerance issues all my life. But somebody here asks about fainting and also overlap with seizures and epilepsy, and how those conditions are sometimes mistaken for one another or can co-occur in the same individual.
Yeah, we have when you get a sudden reduction of blood flow to the brain, you can, and we've seen it in the tilt testing lab, that if hypotension occurs rapidly, that reduction of oxygen to the brain can lead to some shaking, and often it will happen as we are lowering the tilt table down to the horizontal level. But usually after a faint, if you develop shaking or seizure-like activity, it's quite brief in duration and doesn't have major consequences. And it isn't a true seizure disorder. It's just a physiologic response to not getting enough oxygen to the brain at that moment. Others have autonomic features from their seizure focus. So they can have lightheadedness and fatigue, in part because their seizure is not being adequately controlled. And we've had a number of patients over the years who have both, and it's often very tough to tell which thing is driving the process if you have both orthostatic intolerance and seizures. And it may be that for some people, if they've got orthostatic intolerance, one of the things that will make the seizure focus in the brain more irritable is not getting enough blood flow to it. So we've had a couple of patients whose seizure disorder seemed easier to manage when they were put on salt tablets and one of the medicines I described. But I think what I always try to get is good collaboration with our epilepsy specialists because it's often very tricky to sort out which one is which. Robert Sheldon in Calgary, who's a very big contributor in the area of syncope, has written a very nice paper on distinguishing epilepsy from syncope, from faint, from vasodepressor or neurally mediated mechanisms. And among the things that people with seizures do is they have a lot of automatic movements right before they will faint and lose consciousness. They'll pick at their clothes, they'll smack their lips, they'll turn their head, and those are features that are more suggestive of seizure than of syncope. But as I mentioned, it's not always simple to sort out.
And yeah, I'm just looking through questions here. Tilt test.
Yeah.
Does passing a tilt test one time exclude the possibility of orthostatic intolerance, and is it worthwhile getting a tilt test if your healthcare professional is willing to do some trial and error medication?
So the first question is largely wrapped up in the fact that there are a lot of ways of messing up a tilt test. we would often, in the early days of doing a lot more of them than we do now, see people who'd been evaluated somewhere else. We did our tilt tests in a room with a 72-degree temperature. It was a walled-off room with no other noise distractions, and we watched people like a hawk to make sure they weren't shifting their weight, wiggling their toes, and doing something to use their muscle pump to counteract what we were trying to provoke. Example was a lady from New Jersey who came down to see us, and she had her first tilt test in a room where there was a curtain pulled across, and the guy in the next stall was doing an exercise test, grunting and sweating away, making a lot of noise, and it was a very distracting environment, and she was moving around a lot. When we tilted her, she was very positive. So a lot depends on the methodology. The tilt test results can vary depending on when you last had something to eat or drink, the temperature in the room, a variety of these other methodologic factors. So it's not a well standardized test in all settings. It can be made to be positive the more painful stimuli you have. So if you have an arterial monitoring line, people will have more syncope than if you just have a venous monitoring line. So those are among the methodologic problems. If you've got really a lot of orthostatic symptoms, you've probably got something that we could eventually measure to be abnormal. You don't have to have a tilt test, though. The cardiology community has said if you've got a classic history for recurrent fainting and you've got a normal cardiac examination, normal ECG and echocardiogram, you don't absolutely have to, in all situations, get a tilt test. You can begin empiric trials of therapy with your doctor in that setting. The tilt test has become more useful for people with atypical forms of fainting or recurrent forms that are difficult to manage. So in the beginning, we were all excited about this as a diagnostic test that would help get people with CFS better treatment, and that I think was the case, but we've evolved to the point where we don't have to do that to begin trials of medication.
I know when this link was first made back in the mid-90s, there were a lot of people suggesting sort of home tilt tests and different ways to provoke symptoms upon standing and things some physicians were doing in their offices. Is there any risk that you would just put out there?
Yeah, I think
people trying to do this on their own.
Right. You don't want to do it without somebody there to help you, because if you're doing it in your dining room and you lose consciousness and whack your head against the dining room table, you will not have been helped. It has to be done with somebody observing the person. It can be done in an office setting. It only takes the 5 minutes of lying down, the 10 minutes upright, and the 5 minutes of recovery. But that's a lot for a busy general practice office, and so the physicians there would need to set aside time. But it's pretty simple to do, and you can get great information for teaching the patients about what's going on, because as you watch them standing and they're developing the symptoms they've just been telling you about, they feel hot, they're more tired, they can't respond to your questions as well, over the course of just 10 minutes you realize if you can't stand still for 10 minutes without symptoms, you're going to have trouble the rest of the day too. So the standing test, when it's done in a clinic with proper monitoring and nobody leaving the room and the patient unattended, can be very helpful.
Good. What is the outlook, the clinical outlook for people who identify this and find a responsive healthcare practitioner? Your data would indicate that there is some measure of improvement.
Yeah, and what has been the source of chagrin for us is that just making this diagnosis and trying the medications is not the whole ball of wax. Some people have lovely initial responses, like that boy I wanted to present today. And you don't have to go a whole lot further with him. Once people get active with whatever treatment we've provided, they stay pretty good. But there are a lot of people who have a number of other comorbid factors that you have to peel away. They might have a lot of movement restrictions that require some period of time with somebody who does good manual physical therapy. They might have anxiety that you need to bring under control. So we will keep working with them and making changes till we get them to the point where they're functioning pretty well and able to engage in a modest amount of exercise every day. And once that's happening, they tend to improve a bit more on their own as they strengthen the muscles that pump blood up from the legs. But there are also patients that we've been very puzzled with over the years who we have thrown the kitchen sink at, and we can't get them better. And in that group, we wonder about, are they perhaps the people who have one of these poorly defined newer chronic infections? Do they have Lyme disease that has not been easily identified? There are a lot of other possibilities that might apply. Not much literature to help guide us in that area because these kinds of difficult clinical follow-up studies are just not funded these days.
Yeah, unfortunately that seems to be the case all around.
I'll mention, Kim, that even with Midodrine, we presented a trial proposal to the company back in 1998 and had a simultaneous application to the NIH CFS panel for a randomized crossover trial of Midodrine, and we were told it wasn't innovative enough and that it wouldn't be funded. So sometimes it's just the limited pot of money available for CFS work at the national level.
Maybe we can get Sarah Blakely, the creator of Spanx, to make a clinical trial.
I have no objection to trying to ask her.
Okay. Well, we have reached the end of our 90 minutes, and you've been most generous with sharing your experience and expertise with us. And there are still quite a few questions that are left outstanding. I'll just make some closing comments here. Don't go in saunas. Don't go in hot tubs. Those are all the kind of provoking incidents that Dr. Rowe was mentioning are best to avoid if you have these issues. And we will try to follow up with some more of this information, not only in the follow-up email that you'll receive after today's program, but also in future publications. Our September CFIDS link will go out this afternoon, and this recording will be posted on our YouTube channel sometime in the next day or two. And we thank you for all the questions that people have sent in, and Peter, for sharing your knowledge with us.
My pleasure. Thank you.
We've got, whoops, I think I just did myself in here. We've got a couple more programs in September. Gosh, and I can't seem to get to them. Upcoming webinars. In about 2 weeks' time, Tony Komaroff from Harvard Medical School will be with us for a program on CFS and the viral connection, which we had planned several weeks before we knew the Lowe Alter paper on XMRV MULVs was coming out. So Tony's willingness to share that new information, as well as linking back to some of the other infections that have been associated with CFS over time, is quite timely. And then in October, we've got 2 programs planned, one on the association's research program. And Marvin Meadow had been with us back earlier in the spring. He's one of our funded investigators and works with Julian Stewart, who Peter mentioned, and that will be one of the topics that Suzanne will address on October 5th. And then toward the end of October, on the 21st, Morris Papernick from Hartford Hospital. Many of you may recognize him from being in Chicago. He has moved a couple of years ago and is now in Connecticut, but he'll cover some of the other comorbid conditions, and I'm sure that the topic of orthostatic intolerance will come up again in that presentation. And then we have other programs through the rest of the year. So this webinar series continues, and we've got some great topics in store. So we'll leave you with this slide where you can find more information out about those webinars, our Solve CFS Biobank, and where to get information either about our CFIDS Link newsletter if you're not already a subscriber to our free monthly newsletter, and also our Facebook page where we post a lot of breaking news. And again, thank you so much, Peter, for your time and your work over the years. Many people have sent me thank you to Dr. Rowe messages, so I'm passing those along on their behalf as well as my own.
Great. Thank you very much. Appreciate that.
It's been a tremendous addition to not only this series, but the field over the last 15 years. So thank you for hanging in there with us.
Will do. Well, I plan to keep going.
Me too. We'll get this thing solved. Okay. Well, everyone have a good rest of your day, and we thank you again for participating and staying beyond the time. Thanks for another good program. Take care. Bye-bye.